Hello everyone and welcome to this session. Um this session is about digital healthcare in developing countries and specifically I'm presenting about the project Digitalizing Mental Health Care Access in Uganda. My name is John Black Kabuche. I'm a medical doctor and health informatics practitioner at the Uganda Cancer Institute. And I'm working on this project together with John Owol from SPIDER at Stockholm University, Peter Shell from RISE, Juliet Naku, who is the Executive Director of Botavika National Mental Hospital, and Vincent Chibelu, who is a Health Informatics Researcher from Makerere University. So the project is about improving access to mental health care services in Uganda through digital health. And we are going to be carrying out a needs assessment and stakeholder engagement to identify gaps and opportunities for digitalization, but also to develop and pilot a digital mental health care service at the Botavika National Mental Hospital in Uganda. As way of background, mental health conditions are very common. Up 1 in every 4 persons suffers from some kind of mental health disorder. Of course, the severity ranges from those that you might think are simple, like anxiety or panic disorders, to others that are very severe and always more worrying, like alcohol and drug disuse, depression, schizophrenia, and some of these can even result into suicide. The problem is that there is less attention to mental health conditions globally, and as you can see, according to WHO, only 2% of the healthcare budget was allocated to mental health in 2017. This, of course, is even severe in low and middle income countries, which where the healthcare systems are already struggling with other conditions such as HIV/AIDS, malaria, tuberculosis, and other priority areas. In Uganda, the picture is not better. Depression is very prevalent. Some studies have indicated up to 24% of the population. Alcohol use is quite high. At some point, Uganda was ranked as the number 1 in Africa and the 8th in the world. There is a big treatment gap of up to 85%, and this is attributed to many things, one of them being few mental health care practitioners and lack of awareness and cultural beliefs. For example, in witchcraft, which reduces health seeking. So as you can see, only 1.3% of the population that has probable alcohol use disorder contact healthcare workers to get treatment. So healthcare for mental health disorders in Uganda is provided as follows. There is several primary healthcare centers where you find a mental health nurse, and this can deal with simple triage and referral. And then at 13 regional hospitals, there's a psychiatrist sometimes or a physician assistant, and then 1 national hospital which deals with the severe conditions and training and inpatient care. There's few social workers and limited community-based services. And remember, this care is for Uganda, which is 40 million people. So you can put that into perspective. So the barriers then include long distances to the nearest mental health care service center, as you can see. Almost about 20 or so specialist centers for the whole country. And then you have socio-economic issues, poverty, stigma, mental health conditions. People are looked at as mad and they are outcast and they should be locked up somewhere. And then, of course, literacy that can affect people's ability to consume health information and act upon their conditions or to seek care. So how do we overcome these issues, these limitations? We think we can take advantage of the digital revolution, especially mobile health, given that there is a high penetration of mobile phones. They're acceptable and they're being used not only in healthcare but in other industry or service areas. For example, mobile money or mobile banking has taken root in Uganda and other African countries. So we can based on that to also use for healthcare. We think that then using tele services like this, we will be able to share the limited mental health care expertise. Usually that is limited to city centers for people in the rural areas also to access these providers. And then overall we shall be able to improve healthcare delivery or strengthen the healthcare system. So, and of course, we digitalize or we propose digitalization because there has been positive experience. There's evidence, for example, in Sweden with 1177 word guidance, but also specifically, we've been implementing similar services. For example, at the Uganda Cancer Institute, where we implemented an IVR system for awareness and it was successful. And then, of course, there's been the COVID pandemic that has showed us that we all need to digitalize all our service delivery because then we can sometimes not be able to access physical care. So the intervention that we're working on is a tele-mental health system or service, and it has two distinct components. One is an automated component, the interactive voice response system, where we shall have pre-recorded messages. At the beginning, it's going to be in English and Luganda. Remember, Uganda has about 50 different languages, but English and Luganda are the most commonly spoken. And this information will be about common things like signs and symptoms, where to get health care, referral, and practical advice. Of course, this will be informed by stakeholder engagement to decide what the content should be, and then we can curate it in a way that it answers people's queries. The second component will be a linkage. So the system will be able to link callers to peer support workers. Most of these are going to be expert patients or patients who have had a lived experience of mental health conditions themselves, and they are now stable and they can provide advice to others. This is very important because one, it empowers patients or survivors, if you may, but also people like to listen and get advice from those who have gone through the same experience, as opposed to clinicians who might just be speaking from a more theoretical standpoint. Of course, we will also have trained mental health care workers, such as nurses and counselors, who will also provide peer support and also oversee the advice and the interactions between the expert patients and the clients. So people will be accessing this system, the IVR, via basic phone calls. They will be toll-free so that we remove the barrier of phone credit. And of course, IVR can be accessed using any basic phone. So we provide a wide coverage. There's no need for smartphones or internet. And then we'll, of course, use best practices, especially user-centered design and participatory design, to do a comprehensive needs assessment, to test and to do formative evaluations, to make sure that we address all usability issues, acceptability issues, and develop content that is contextualized to the Ugandan context. And then we foresee that this system will help in strengthening of the healthcare system. One, improving mental health care service or access to mental health care service, but also in raising awareness and reducing stigma and encouraging people to seek care, because now we shall be telling them about these conditions and where to get care. But also we empower patients and reduce patients and the survivors or people with lived experience, and reduce the patient load that healthcare workers have to deal with. Lastly, we see that this is going to be a basis for future studies on key issues in digitalizing mental health care. One of them being the therapeutic alliance and provider-client relationship. This needs to be investigated. It's very critical in mental health care service delivery. The relationship the patient has with the provider. Also, there is potential for other digitalization undertakings. For example, using chatbots and conversation agents to automate the interactions. And then when you empower patients, you also want to have them self-manage, but also you'll be able to assess them through patient-reported outcomes. So that's briefly about DIMA, or Digitalization of Mental Health Access in Uganda. And this is the team, John from Stockholm University, Peter from Rice, Juliet Naku from the Butabika Mental Hospital, where this service is going to be implemented, Vincent, and myself, John Black-Karuche. Thank you for listening, and we can now take any questions that you might have or comments. Thank you.